Hello, listeners. Thank you for tuning in. My name is Nathan Marlowe. I am a physician assistant student at Drexel University, and this podcast will be discussing the chronic pain condition known as complex regional pain syndrome. The purpose of this podcast is to help educate primary care providers about this condition in hopes of speeding up a diagnosis. The first half of the podcast will be discussing the condition itself, clinical features, and management. And the second half of the podcast is going to be an interview between myself and a patient who has this condition. We'll be hearing from her about the role of her primary care team and some of the elements that she thinks is important for primary care providers to know when managing patients with this condition. So, complex regional pain syndrome, also known as CRPS, is defined as, quote, CRPS describes an array of painful conditions that are characterized by a continuing, spontaneous, and/or evoked regional pain that is seemingly disproportionate in time or degree to the usual course of any known trauma or other lesion. The pain is regional, not any specific nerve territory or dermatome, and usually has a distal predominance of abnormal sensory, motor, pseudomotor, vasomotor, and/or trophic findings. And the syndrome shows a variable progression over time. So CRPS itself has had different names in the past, and that is shown within the two subtypes. So type 1, which was formerly known as reflex sympathetic dystrophy, corresponds with patients who have CRPS without any sort of evidence of a peripheral nerve injury. And this is the most common type of CRPS. We see it in 90% of people who present clinically. The other type was formerly known as causalgia, and this refers to cases where there is a peripheral nerve injury present. So looking at the pathogenesis of CRPS, it still remains unknown. There are a few theories that can explain the persistent pain and allodynia that is the hallmark of CRPS. And some of those look at classical inflammation, neurogenic inflammation, and changes within the central nervous system itself. So patients who have CRPS have been found to have higher levels of pro-inflammatory cytokines within their affected areas, but as well as within the plasma and the cerebrospinal fluid. And so the persistent pain and allodynia is caused by a consistent release of these inflammatory mediators and pain-producing peptides in the peripheral tissue. That's more of the classic inflammatory model. The neurogenic model looks more at nerve impulses that come more proximal to distal and cause a greater release in neuropeptides in the periphery. So it's coming a little more centrally. And then to kind of continue on that chain, there's the central nervous system changes that look at what they call central sensitization. And there's an increased activity in some of the nociceptive afferent neurons due to an increased stimuli in the peripheral neurons, so damaged tissue, inflammation. And so there's a greater release of neurotransmitters into the somatosensory cortex, and then you have this heightened pain response. And part of that as well is that CRPS over time can migrate. The pain can migrate. And that is believed to be caused by what they call arborization of neurons in the somatosensory cortex, where it's basically like the neuron is fanning out arbor, like a tree, and affecting more areas. There's also some discussion of the sympathetic nervous system and how it is related to CRPS, because as I'll be discussing later, some of the signs and symptoms are related to the sympathetic nervous system. And so there is some discussion about basically catecholamine hypersensitivity. And so when epinephrine is released into the peripheral tissues, it causes a greater pain response in those areas. So who gets CRPS? Let's talk about epidemiology a little bit. CRPS is more common in women than men at about a 2-to-1 ratio, and the incidence appears to be highest in women who are postmenopausal. And this is important because the most common inciting element to CRPS is a fracture. About 44% of patients who present with CRPS have a history of a fracture as an inciting event. So women who are aging and have lower estrogen levels, decreasing bone density, they're more likely to have fractures. And usually it's in the upper extremity over the lower extremities. But it is possible for patients to get CRPS from non-fractures. So any sort of blunt trauma or surgery or really anything where there is damage to peripheral nerves can eventually lead to CRPS. So it's important to think with your differential when you're seeing a patient who comes in and is having pain and hypersensitivity significantly longer than you would expect for an injury. So let's go ahead and begin to discuss the clinical manifestations of CRPS. This is the really important element of this podcast that I want you to pay attention to, because the condition isn't diagnosed on lab values or with diagnostic imaging. There aren't strong correlations between diagnostic imaging and finding CRPS. It really is clinically diagnosed. So the Budapest criteria was created, and what that is 4 categories, and you need to have at least one symptom from 3 of the 4 categories. So the 4 categories are sensory, vasomotor, pseudomotor, and motor and trophic. And so within the sensory, if a patient is reporting hyperesthesia or allodynia, within the vasomotor, they will report temperature changes or skin color changes. Within pseudomotor, they'll be describing edema or changes in sweating within affected areas. And then the motor and trophic will look at decreased range of motion or muscle function, and as well as trophic changes within the hair, nail, and skin. So I'd like to begin talking more about pain. Pain is definitely the most prominent and debilitating element of CRPS. The pain normally is described as burning, stinging, or tearing, and that can be deep within the affected area or superficial. The pain normally is described as continuous, but it can undulate. It can rise and fall. The pain can be exacerbated by movement, changes in temperature, stress, physical contact with the area. So when you're conducting a physical exam and getting a history from somebody who you suspect may have CRPS, spend a lot of time talking about their pain. So do a really good OPQRST on their pain in order to understand all of the elements that go into it, understand the trigger, understand how it resolves, how it changes its character. All of these pieces of information are crucial in helping make a diagnosis for CRPS. And one of the greatest things that will stand out with these patients is that allodynia, that hypersensitivity. When you go to touch them and examine the area, the minor stimulus that you might be producing may seem insignificant to many, but for some who have CRPS, it is truly excruciatingly painful. So be very careful when examining these people. And the next thing I want to talk about is the motor changes with patients who have CRPS. So approximately 2/3 of patients who have CRPS in a limb will show some motor impairments within that limb. And what that can look like is decreased range of motion, decreased muscle tone, decreased muscle strength. The limb itself may be limited because of edema or pain. There might be even tremors or dystonic postures that can be in play. So look at how a person is carrying themselves within your exam and do some good muscle testing. Check their range of motion, check their strength, and you'll be able to see a discrepancy between the healthy limb and the limb with CRPS. The next clinical symptom I want to discuss is autonomic changes. So looking at skin temperature, looking at skin color, looking at sweat production, and edema. And all of these are very common symptoms with CRPS. There's something called the CRPS flush, which is basically a flush of red, splotchy looking skin in the areas that are affected by this condition. So that can be a telltale sign, especially when someone is either stressed or warm. It can cause this flush to occur. So looking at the affected areas, if you see color changes, if you see abnormal sweating in the one area as opposed to another, if there is edema, all of these elements will help you make a clinical decision that maybe there's CRPS going on in this affected area. One of the other changes that we see are trophic changes, and that's looking at sort of how the connective tissue in patients with CRPS will change a little. And that can look like increased hair growth in the affected area, changes in nail growth, either increased or decreased, and atrophy of the skin itself. So looking at it and seeing if there's any breakdown or thinness relative to other areas. So these are the most common signs and symptoms with patients who have CRPS. So hopefully when a patient comes in and they're having pain and it doesn't make a lot of sense and it's been around for a long time, you start to think about the possibility of this person having CRPS and spend the time to do a good history and physical exam in order to look for these changes and see if you can get this person connected to the right people. So going forward, we're going to be discussing management and referral because that's such a crucial element for primary care providers. When managing patients with CRPS, the multidisciplinary approach is really recommended. Getting providers who are in physical therapy, occupational therapy, pain management, neurology, psychology, just mental health in general is really helpful. There are multiple facets to having this condition, and having these different providers approach the condition and help these patients in the various ways tends to have significantly better outcomes than when they're just being managed solely by one provider. So I'll spend a little bit of time discussing each element of management, looking at specifically physical therapy, pharmacologic therapy, and then various interventional procedures that can be performed to help individuals with CRPS. So, as previously mentioned in the podcast, we know that CRPS has a motor impairment element. And this is where a physical therapist or an occupational therapist can be extremely valuable in helping these patients get their range of motion back, build up strength in the limb. And PT and OT are considered first-line treatments for CRPS. There have been a few studies that have looked at various techniques such as graded motor imagery, pain exposure, thermal and sensory desensitization therapies, all in hopes to decrease the heightened pain response and normalize that for patients and hopefully get them to completely resolve their symptoms of CRPS. So having a physical therapist on board to help with functional movements and an occupational therapist as well to help with daily living can be really crucial for these patients because they're in significant pain and much of the time they are guarding or not utilizing their affected areas appropriately. So when looking at managing these patients from a pharmacologic standpoint, this is where you, as the primary care provider, will play a significantly greater role. So there is a broad range of medications that have been used and studied with patients who have CRPS. And beginning, we use very similar medications we would use for other people in pain. So NSAIDs are one of the first initial treatments for these patients. There doesn't seem to be a significant effect for patients with CRPS, especially chronically. But again, these patients are all going to present a little differently. So all the medicines I'm going to discuss, just think about them as you are treating these patients and see what is being effective for others. So NSAIDs are a great way to begin. Another classic medicine that's used for these patients is an anticonvulsant, which is gabapentin, which is known for neuropathic pain and has shown some effect for patients who have CRPS, again, with some varying levels of effectiveness. Another neuropathic pain treatment is topical lidocaine and capsaicin cream. So the research studying these creams specifically with CRPS is limited. However, it is utilized fairly frequently when managing these patients. A big medication that is utilized frequently throughout the medical world, especially when there is an inflammatory issue, is glucocorticoids. So early on in the course of patients with CRPS, they might have some mild resolve of their symptoms utilizing steroids. However, as time goes on and the condition becomes more chronic, they'll have less and less of a response to the steroid. So it's not a bad thing to begin with. However, if someone's been managing this pain for a significantly long period of time, don't be surprised if your patients don't get great results from utilizing steroids. So, two other important medications I want to discuss in regard to pain management are opioids and ketamine. So, opioids are the classic go to pain medication with people who have refractory pain that is still very severe. And utilizing opioids for neuropathic pain has been pretty controversial, and there really isn't great evidence for treating patients with CRPS with opioids, especially as the pain can be refractory and fairly severe. We tend to titrate the opioids higher and higher, and then the side effects significantly outweigh any benefit. So, in light of that, providers are using ketamine far more frequently, and especially ketamine infusions. And there have been some research studies have shown that patients can get significant relief for up to 12 weeks after having these kinds of infusions. But the important thing to educate your patients about prior to engaging in these sorts of therapies is discussing the psychomimetic effects of ketamine, such as the hallucinations, delirium, and other side effects such as nausea and vomiting that comes with ketamine. However, primary care providers are not the ones performing these types of treatments, especially ketamine infusions. That's going to be more in the realm of pain management or neurology. But it's important for PCPs, as you well know, to educate your patients about what other therapies can look like prior to referring them to those specialists. So, most of the medications I've discussed up until this point have been focusing on pain management. And that is a huge, huge component when managing patients with CRPS. However, there are other components to this condition that need to be managed and can be pharmacologically managed. So, one that is recommended is an antidepressant, either a tricyclic or an SSRI, something that can help treat the psychological element of having a chronic pain condition, but also there seems to be some research that suggests antidepressants do have positive effects on patients with neuropathic pain. So it is definitely something worth trying in order to help the patient feel better in general, but also potentially decrease their pain. Another element to manage with CRPS is actually loss of bone in the affected areas. So they've found with patients who have chronic CRPS that there's increased osteoclast activity, and so you have bone demineralization, and eventually you can see that on X-ray, but it takes quite a while before any of that occurs. So from a pharmacologic standpoint, utilizing medications such as bisphosphonates or calcitonin can help with that loss of bone and decreasing osteoclast activity. So that's a brief overview of some of the pharmacologic therapies that are utilized when treating CRPS. But another important element that needs to be discussed is interventional procedures that are used for these patients. And usually these are used by pain management specialists or neurologists, and usually for people who have chronic CRPS. So the first type of interventional procedure are injections, and injections in various areas and also with various contents. So trigger point injections are utilized with a local anesthetic to help relax musculature around affected areas. There is some benefit to that with range of motion and motor function. There are also regional sympathetic nerve blocks that are utilized. However, this is very clinician dependent and can have significantly varying effects. There are also epidural injections. Epidural clonidine has been utilized. However, there isn't strong evidence to suggest it's incredibly effective for patients with CRPS. For patients who have chronic CRPS and don't respond well to some of the earlier interventions, there is the use of spinal cord stimulators. And so spinal cord stimulators are basically an implantable device that has leads that go directly into the level of the spine where you're having the affected area. And spinal cord stimulators have shown good effect, especially with patients who have their affected area in one upper extremity, so right or left side, and there seems to be good results with that. However, there also seems to be some discussion around the fact that it's very clinician dependent as well. The leads that are placed can be done in different ways, and there can be lead migration and also just the placement of the device itself and the various settings. So there continues to be research looking at the effectiveness of spinal cord stimulators in managing patients with CRPS. So we've talked about various management and the clinical aspect of assessing and diagnosing, but what's the prognosis for patients with CRPS? The fact of the matter is it really is very variable, and it depends on the level of injury and the length of time. There definitely seems to be a connection between individuals who have this pain condition for an extended period of time and their ability for that pain to resolve. For certain individuals, their pain will resolve with physical therapy and kind of earlier on interventions, but others, the pain can be refractory and it can stick around and migrate over time, like I mentioned earlier in the podcast. So it's important to treat this condition as early on as possible, and that's what this whole podcast is about, is trying to help you as primary care providers recognize the signs and symptoms of this condition and make appropriate referrals, because it really is time dependent on their ability to heal from this condition entirely. So now that we've learned about CRPS and how to manage it, we're going to actually transition into our interview portion of the program, and we'll be hearing from a patient who has CRPS and has been managing it for some time. Her name is Margie, and she will be discussing with us the impact her primary care team has had over the course of her disease, and also some advice that she wants to give primary care providers when managing patients with this condition. So the interview I did was with her in her home, so you might hear some background noise, but just try and focus on the message she's trying to send. Margie, thank you so much for being here. We're really excited to hear from you to help us continue to diagnose this condition a little bit more quickly.
You're welcome.
So, Margie, to begin, how long have you been managing your CRPS?
When I was finally diagnosed with it, it's been 15 years, but I've been symptomatic with issues much longer than that. Probably
Okay.
The easiest way to say it would be like over 30 years.
Okay, so you had symptoms for quite a long time
Yes.
before anyone figured out
Yes.
that this is a big
Yes.
part of what was going on.
Mm-hmm.
Okay.
Absolutely. And for me, it was in the face that it started,
Okay.
and still seems to be the center of issues. I had, what we thought at the time was a severe case of TMJ. 5 surgeries later, I had my entire right joint replaced, and the tissue healed fine and the joint worked great, but I was still in severe pain.
Okay. Did you have, after your surgery, did you have any decrease in your pain for any period of time, or was your pain fairly constant?
It was really constant,
Okay.
and it was really tough.
Yeah, I
And it
can
was
imagine.
tough once the quote-unquote surgical pain backed down to still be in severe pain.
Right, absolutely. I
Yeah.
imagine that would be incredibly frustrating.
Yeah, the nature of the pain started to change a bit. It involved things like sweating, flushing. I still would get these very intense one-sided face flushes, which
Mhm.
of course is a little hallmark of CRPS.
Yep.
And the electric flashes and burning up the face and into the eye. I would complain to the surgeon about having tendinitis. I used to get a really bad form of tendinitis in my face. And I would say, I think I have tendinitis. And he would say, you can't, because I took that tendon out.
Okay. Yeah.
And I would
Yeah.
be like, oh man, okay, that's weird. So, and headaches, things like that.
Okay.
So we were, as I healed and I could actually chew again, I had been on liquids for 7 years.
Wow.
Prior to that, I could chew again, but the pain was there and we had no idea what to do.
Okay. Gotcha. That's amazing you had that pain for so long.
Mm-hmm.
And then even after, that led to your surgery, and then following,
Right.
here you're hoping for this big resolve.
And it was really clear that I needed the surgery because I ended up having avascular necrosis in my mandible. The bone was dead.
Yeah.
That explained a lot of pain.
Absolutely.
So the surgeon, coming out said, "We've got it, Margie, we've got it. You're going to have a life." I was thrilled.
Absolutely. And then unfortunately the pain sort of stuck around. So how long, I guess then after your surgery, was it until...
It was about 2 years.
Okay, so your doctors were kind of beginning to question what's
lot.
going on here,
We were all questioning, and of course I was beginning to think I was a nut job.
Yeah, I can imagine.
Because it was very, very difficult.
Yeah. Okay.
Yeah.
And how many, how many providers were working with you at this point and kind of leading into your diagnosis?
Well, I sort of, for the sake of this interview, I did some counting. So up and including my diagnosis now and who I'm treated by now, it was 10, which is surprisingly small, I think.
Yeah.
In light of what I'm doing. And part of that is a tribute to where I live, because it's a really saturated and wonderful place for medical treatment, my city, but also a tribute to the guys who worked with my jaw, because they were very restrained in surgical intervention, and I stayed with them. Also a tribute to my primary care docs as well, for not just pushing me out again and again.
Yeah.
We try to really stay away from that. And also getting lucky.
Yeah.
Getting a good run
factor.
at neurologists.
Yeah.
Yeah.
So you're currently being managed by a neurologist,
Yes.
Is that correct?
No, actually I'm being managed by a pain doc whose primary training is anesthesiologist, as an anesthesiologist. But I do have a well-known neurologist that I see because all he does is CRPS.
Okay.
But his sort of hand-holding day-to-day care isn't as nice as the pain docs. So I work them together and they're quite happy with that, and I'm quite happy with that.
Good, yeah. And sometimes you have to see what works for you.
Exactly.
And,
he's the pain doc is much more available. He's much more creative. The neurologist who only does CRPS is doing all sorts of edgy stuff that I want to be aware of, and so far I haven't fit into any of the trials that he's been doing. But I want to know about him, and I want to be on his radar screen, so it works well.
Yeah.
And he's quite happy with it, to follow my different path and see how I'm responding. So it's a good, it just means I have to communicate to everyone very clearly and very carefully, and I'm down with that.
So Margie, one of the big goals of this podcast is to help primary care providers recognize the signs and symptoms of CRPS and just be able to assess it and diagnose it sooner, and help patients like yourself connect with the right providers to help them get that proper diagnosis. So I'd love to talk to you about, if you remember, I know this was a long time ago, but some of your initial interactions with your primary care providers, what they did well, what they could have done better, and then sort of the evolution of how your primary care provider has walked with you through this journey of managing CRPS.
Yeah, and I think, for the purpose of this, I've thought about my most recent 3 primary care providers. And the one was seeing me during the time I was having the jaw surgeries. And it was about a year before I had the jaw replaced that we sought out a naturopathic approach.
Okay.
I was on liquids, I was anemic, I wasn't eating well, and anyway, I did this whole thing, juiced, and I was getting better. I was feeling better. Obviously, I was getting better nutrition. I was talking to my primary care doctor about it, and he just was like, how did I not listen to this? How did we need to approach this differently. Tell me what you're taking what your surgeon is providing for you. And at that time, I was working full time. I was using NSAIDs. I was using muscle relaxants when I needed them, like Flexeril. I was using narcotics, mild, low end, what I think of as low end narcotics now, Ultram, Vicodin. I think we moved from Vicodin to Ultram because I felt like Ultram was a lot less annoying, a lot less strong or euphoric or whatever.
Yeah, it didn't have kind of the same
I
sort of
didn't
high
get the
effect
hangover
or the hangover
from it
effect.
as much, so
Okay.
I would use them at night and work during the day. So
Gotcha.
it was a really kind of a tough time of life,
Yeah.
trying to work and deal with this and bringing bags of juice into work to eat and that
Right.
sort of thing.
Okay.
And he immediately put me on the anti-seizure meds, the Neurontin. We tried several different ones of those. I was already on a tricyclic. I was doing amitriptyline at night, so we upped that. At that time, we backed out like the Lodine, that was the NSAID, and I used Vioxx for that brief period that Vioxx was so fabulous, and then of course people had problems with it, and we moved to Celebrex, but he really, and then we gradually moved me onto oxycodone, oxy-IR, because that was before all the warning things.
Right.
And then I went through my heavier surgeries, so we were using some oxy-IR, OxyContin, because I was out of work, because the surgeries were more severe. And it was at that point that first primary care doc left the practice because he wanted to pursue his specialty in geriatrics.
Okay.
So I was switched to his partner in that practice. She was incredibly uncomfortable with me. She did not like the amount of meds I was on. She treated me through the joint replacement, or right up to the joint replacement. And at that point, interestingly enough, my surgeon was concerned about my med use as well, and suggested that I see a psychopharmacologist. And I was also very depressed at the time. As you would imagine,
Yeah.
chronic pain and depression are twins. And I thought, wow, what a great idea. I had no idea someone existed out there who could, look at the meds and look at the psyche and help me manage this. At that point, I started spreadsheeting my med use because I was terrified about using all these drugs. My husband is an RN, my sister is an NP. These things, we talked about these things very regularly in my world, but it still was what it was. So I asked her, the second one who was uncomfortable, to make a recommendation. Long story short, I ended up with a psychiatrist who wasn't a psychopharmacologist, but who looked at my meds, which in reality were fairly simple, and said, I can handle this. And I began a working relationship with him before my joint was replaced. That was very significant. I have worked with him for 18 years, and
Okay. That's a long relationship.
and I work with him today.
Yeah.
It has definitely had a strong impact on the quality of my life. At that point, I was on an SSRI, on a very high dose of an SSRI. It took 4 or 5 till we got to Lexapro, which I'm on now, a very, very low dose, because I'm not depressed, but we don't want to remove the SSRI so that I can use it if I need it.
Right.
Because of that weird thing about SSRIs. So anyway, so I left her practice, the second PCP practice, because she was so uncomfortable and I was still on these narcotics. And I moved to a third primary care doc who is still my primary care doc.
Okay.
And
So this your third and current primary care doc
yes,
met you with, it sounds like a
I had
boatload of different types of medications,
lot of medications.
lots of narcotics at this point.
I was on not as many as I was going to be on.
Okay.
Because with her, as the pain increased and we discovered that I had needed the joint replaced, and in the end, I was in that avascular necrosis phase.
Mm-hmm.
At that point, I was using fentanyl patches. There were fentanyl lollipops. She was the one using she was the one controlling the narcotics, and and it was scary, because like when I came out of those surgeries, I was on Dilaudid, so we did all these switchovers to the oxys and then the fentanyls to take the oxys down.
Okay.
And again, I was spreadsheeting everything, which made it possible for her to like look at when I was taking things for breakthrough, and we tried to like smooth things out. But anyway, that was before the whole oxy crisis and that sort of thing, before they took the lollipops off the market.
Right, I think things would look a little different today.
Way different. She was worried about it. I was worried about it. So what happened then was she actually wanted me to go to a pain clinic for a second opinion on the meds, and I was all about that.
Yeah.
And it was one of the worst experiences of my life.
Oh. In what aspect was it?
Well,
so
the guy,
was it just the provider you saw, or
it
just
was the provider.
Okay.
He never made eye contact. He looked at my med list, never asked me what was wrong with me, and said, you need to be detoxed, and before I'll treat you, you have to be detoxed.
So, and he just
and
made
that was
that
the end
without...
of the appointment.
Oh my goodness.
And I left weeping because I thought, how in the world am I going to deal with my pain? He never asked me what was wrong with me. And my primary care physician was absolutely outraged because there was no care discussed. And she phoned him and spoke with him and felt like he was basically an idiot. But he was from a very prestigious university pain clinic. So that was very odd and very unhappy. At the same time, we were concerned because we still didn't know what was going on, where my pain was coming from, and what were we going to do. So at that point, a number of random things occurred that my husband was speaking to a neurologist that he worked with, who turned out to be the chief resident of one of the most well-known neurologists who treat and research CRPS. This neurologist, my husband's coworker, was his chief resident. And so my husband said to him, would you see my wife? And he said, yes, I would love to see your wife. So we went to see him, and he immediately said, I think I know what you have. And at that point, we were still calling it RSD.
Right.
And so he was able to get me to see this guy, and usually it took 3 to 4 years to see him and another 3 years to actually be in treatment. But because my primary site was my face, and that was unusual, I got to see him within 3 months, and through another set of circumstances, I began treatment with him, which was ketamine, within another 3 months. And as we began the ketamine protocols, which were very specific and extended for quite a period of time, every time I had ketamine, we would decrease the narcotics.
Okay.
And it was amazing.
And you started getting good results then from the ketamine treatment?
Yes,
okay.
Yes. The pain would go down, and and I would be able to decrease the narcotics. So we obviously started at the high end with the fentanyl patches, and well, the lollipops were the first thing. The fentanyl lollipops went first, and then we started at the 75 mic fentanyl patches and rolled them back, and then rolled everything back, and it took 2 years, 2.5 years, and I was off of all narcotics. And those were a rough 2 years. And my primary care physician was very key during that time, because I had lots of side effects from all of the medications I was on, and she was the one who held my hand through the constipation, the diarrhea, the vomiting, along with the neurologist. But again, he was a tertiary care neurologist. I only saw him when I was gorked on ketamine.
Right.
So I would have to write notes and leave them with the nurses to have him answer questions. So it was my primary care physician who walked me through all of those difficult things. So, she was the one who suggested we use bowel motility drugs to help move the stool along in my colon. And that was genius. That made a huge difference. She was the one who suggested Voltaren gel for my jaw joint, which my jaw surgeon said we just started using that. Isn't that a coincidence? But he had not told me about it. It was my primary care doc who said, I use this with knee patients. You're going to need just a tiny bit. And it really made a difference. It was my primary care doc who suggested lidocaine patches for the allodynia in my arm. It was my nephew in physical therapy school, that isn't right, who was in college looking at the brachial plexus nerve being close to the surface in the armpit, who said, try putting it in your armpit. And that worked great. But then the neurologist started compounding creams of lidocaine and ketamine, and those have been helpful. But again, the tertiary care neurologist said, well, do you know why that works, why the patch works in your armpit, Margie? And I said, because the brachial nerve is close to the skin. And he goes, right. And I'm thinking the whole time, why don't you do that? And he says, well, it's only going to take a 0.5% off your pain. And I'm thinking, I want everything I can get off my pain.
Right. And so you had this big group of people. I mean, it sounds your primary care doc, your pain doc, your neurologist, your family members, people who are all kind of working,
thinking about it
for you
me.
to try and make things work.
Exactly. And the my current primary care physician, felt so vindicated in many ways because I take no narcotics now.
Right.
And yeah, it was really hard and it was really ugly going off of the narcotics, but they were my only choice.
Right. Are you still currently using ketamine?
I am.
Okay.
I am. And I get ketamine. It depends. I'm the one now who determines when I need it. And I basically wait until my pain until I'm living at a 7.
Okay.
With very little relief.
And how long normally between your how long do you get relief?
Sometimes I get 3 months. Sometimes I get 4 to 5 months.
Okay.
It really depends. It depends on the season of the year. It seems like the winter, I live in the north, is harsher on me. I have a harder time dealing with the cold. It also depends on, it's random. And I have to say that that's what I understand is common.
So Margie, I know earlier we mentioned some of the things you've used over the years to try and manage this. If just to kind of give perspective to people listening, would you be willing to list out for me the medications, therapies, things you've tried over the years or are currently still using to help treat your CRPS pain?
Sure. In terms of meds, I've been on multiple anti-seizure meds, tricyclics, narcotics, muscle relaxants, NSAIDs, NSAID creams, maxillatine, clonidine, SSRIs. I've done biofeedback training, acupuncture, TENS units. I've had physical therapy, very, very careful physical therapy, psychotherapy. I have had lidocaine infusions, ketamine infusions. I've had Botox. I've done a spinal cord stimulator trial. I've had stellate ganglion blocks 3 times, 3 different physicians doing the blocks, because apparently everybody does them a little differently. So 3 of those, none of which did anything for me, unfortunately. They made it worse. I've used specially compounded lidocaine creams and specially compounded ketamine creams. I think that covers it.
I mean, that's a very extensive list, and I think the takeaway message that I hope that we can convey to providers is that it takes a lot, and you have to find what works and what helps with your side effects, and ultimately trying to help with your pain. So, if you could, what has been, I guess, the most beneficial, if there is anything necessarily that you've felt as far as reducing your pain?
Sure. Certainly ketamine, the use of ketamine, and I guess another med that goes with ketamine is I get anxiety post-ketamine periodically, so there's Ativan as part of my post-ketamine protocol.
Okay.
I've also used lidocaine infusions for pain, and that has helped. There was a period of time where ketamine just didn't seem to be doing it, so they used lidocaine for a while, but ketamine's working again.
Okay.
So ketamine, the tricyclic amitriptyline works well for me. The compounded creams of lidocaine and ketamine can often take me down a full pain point.
Okay.
If I use them in good timing. The NSAID creams, Voltaren and NSAIDs help with my joint pain. That's probably more about the joint, replace the prosthetic joint than the ketamine, but that's really hard to call. Muscle relaxants, baclofen is the one that they recommend the most for CRPS. I had never been on baclofen until I was diagnosed for CRPS, and they immediately switched me, and it really helped a lot more. The maxillatine and the clonidine are also in my current cocktail, I guess.
Yeah.
And I've gone off and on them, and they seem to be doing something very well. So, and I really, again, push psychotherapy.
Yeah.
Because pain is really hard on your mind.
Yeah. So I think what's interesting is in asking you that question, a lot of people would think it might just be one or two things, but this is a whole bundle of things, really, that has been really beneficial for you, and managing that is...
And it's not static.
Right.
We are always tweaking it. We just started me on Topamax for headaches that we're not sure what the origin is, whether I'm migrainous or whether it's a long-term response to ketamine. We don't know, but it's sort of been helping, and we're trying to figure that out. And that's a combination between my PCP and my pain doctor. So therein is another role that my primary care physician is really filling.
Gotcha. So managing that dynamic nature and understanding that, you're not necessarily going to find one single regimen that's going to work for you all the time. So that is definitely a challenging thing. So, Margie, having 3 primary care providers, I mean, you described already the journey that you took with them and sort of the differences you noticed between them. If you had to summarize 4 primary care providers, what are things that your providers did really well and that you would recommend other providers doing when managing patients with CRPS?
Even I would say speaking the truth is obvious, but telling the patient that you're speaking the truth is important. Even the second physician who wasn't comfortable with me, I sort of admired her for telling me that she wasn't. I didn't feel like she left me in the lurch. Well, I guess I probably did feel like she left me in the lurch, but in retrospect, that's a healthy thing.
Yeah.
Don't treat a patient you're not comfortable with.
Yeah. And being honest when you are having conversations about what's going on and expectations and things of that nature.
Exactly. I also think one of the things that they've done really, really well is talking about my whole person. My current PCP says, you're more than CRPS. And for a CRPS patient, it's really hard to remember that.
Yeah.
CRPS is the elephant in the room.
Right.
So you're really not tuned into the fact that you need to, get the flu shot. You don't really give a rip, but you don't want to get the flu.
Right.
Right. And you don't want to do those other things like the colonoscopies and all that stuff, because you don't want any more pain or more discomfort, because I
Right.
spend a lot of time managing CRPS.
Yeah.
But the bottom line is I have the rest of my body, and so I need that encouragement from my primary care doc. The other thing too is that managing the side effects from everything is really helpful.
Yeah.
And having someone who's going to listen to the whole picture. The neurologist doesn't have time for that.
Right.
But I'm on medications that are prescribed by my pain doctor, my neurologist. There are meds that I take only when I get ketamine.
Right.
Like an anti-anxiety medication, I take a little Ativan, that sort of thing. So having someone who has the knowledge of everything, and it seems like that's a perfect role for the primary care doc, because I know she looks at everything and we discuss it.
Right.
And
they
sometimes she makes recommendations.
Yeah, and they have that sort of the ability to have the bird's eye view.
Yes.
And be able to look at everything and make sure that things are working for you. And then, if need be, talk to the other providers to try and optimize what's going on.
And I think if a CRPS patient isn't doing anything about depression, isn't seeing a mental health professional, I have had an incredibly successful relationship with a mental health professional. I can't imagine living with this condition without that help.
So recommending that primary care providers encourage their patients to seek out a mental health professional.
Beyond just putting them on an SSRI.
Right.
And because, like I said, it took multiple SSRIs to find the one that helped. And I know that patients, I've been through almost every NSAID there is out there. I've been on lots of medications, and I know lots of patients are compliant. But I would just encourage the primary care doc to just really hang in there with them and teach the patient that it's okay that the med didn't work. There are lots of other meds out there, and that's the way it works chemically. You gotta find the right match. I needed to understand that.
Right.
I didn't know that that's the way it works.
Right. So someone who could help describe and educate you on the whole process, because you were describing earlier all these medications that you were on and how they all work differently, and I guess having somebody who will take the time to explain everything, but also have the longevity to say, this isn't working for you, let's try this, and here's how that worked.
And it can be a highly emotional thing. I tend to make decisions analytically, which is why I think it was as easy, even though it wasn't easy, for me to decrease the narcotics. Being told that they weren't good for me, that they didn't really help the pain, was part of the motivation of doing that. But I also knew that if I took more, I'd be vomiting less or having less diarrhea, but I could make that more a mental decision. I don't make I don't have a feeling approach to decision making, and that was helpful for me. But I think, but I was encouraged that way. I was encouraged by having explanations. And I think learning your patient's way of thinking and helping them understand, that really helped me. That helps me now to understand the best way to go. And my primary care doc is the one who helps me figure stuff out.
Yeah.
And I'm really grateful for that. I think the other thing that's kind of funny is don't touch your CRPS patients in the areas that they hurt. Touch lasts for a long time.
Mm.
So my issues in my face, and if I have like a bad cold, I love my PCP. She's been with me for a long time, but she still reaches for my glands, and I have to go,
Right, it's autopilot for
yeah.
her, I imagine.
And I say, ooh, remember, don't. And she goes, oh, Margie, I really need to. And I'm like, okay, then let's, do it. I need to be prepared for that,
Right.
So she's really gentle, or she goes, okay, I'm not going to do it. I can see your throat. We talk about it together. The whole right side of my face, if she sticks her little ear thingy in there in a wrong way, I'm going to feel it for the rest of the day.
Yeah. Where for some of us, that's, just it's not as big of a deal, but
Right.
for you, this is an incredibly important thing.
Yes.
So having someone who is conscientious of that while they're examining you,
yes. And
sense.
hopefully your CRPS patient, will tell them not to put the blood pressure cuff on the right arm if that's your affected arm.
Right.
But those things, it feels nice to be known.
Absolutely.
That we're sensitive.
Yeah, and being mindful of that as they're engaging with you.
Yeah.
I guess to continue on from that, are there any other bits of advice like that you would tell to your primary care provider?
There was this one thing that I found really comforting when I was on a lot of medications, but also had no idea that in primary care practices, I had to see one of the other providers in the practice for a cold or something, and when he pulled up my chart, he said, oh, I know who you are. We talk about you because of your CRPS and your medications.
Hmm.
And I thought, oh, that makes me feel so good. That makes me feel like my doctor isn't the only one who knows, it means I can go to anyone in this practice and you're not going to say, what is going on with you?
Right.
They're going to say, oh, you're that patient, because I was very unusual at that time. I was on a lot of narcotics when that happened. And even to this day, when I see him, we speak of my CRPS because he has had other CRPS patients. And I'm grateful for that.
Yeah, so
it's a silly thing.
Well, I mean,
but not.
That's great. I mean, because medicine is a team approach, and when you go into an office, you're seeing a lot more than just your doctor. So or your provider, having someone who will discuss it with the team and give you that feeling of being heard and validated on a team level that sounds great.
Yes, and that other issue of being heard, I think, is a big one, because my primary care doctor really took my pain seriously, and my journey was circuitous, and not as circuitous as many people's journeys, but there were certainly seasons where I thought, I must be insane. I must have a mental problem. This pain, am I making this up? And she always validated my circumstance. She always listened to it. She treated it seriously, and that helped me treat it seriously too, and not slide deeper into depression. She has always been my cheerleader, and I'm so grateful for that, because it's a hard thing to live with. And so to hear her say, Margie, I think you're doing well, or I'm sorry you're going through a hard time today. Is there anything else you can think that I can do for you? Just even having her say that, even though I know there really isn't anything she can do for me, just is lovely.
Yeah.
It's just lovely.
Gotcha. That's great. Well, Margie, thank you so much for taking the time to speak with me today. And I really hope that our conversation today will help other providers, help people who are in your position, and so we wish you the best of luck going forward managing this condition. And again, thank you so much for your time.
You are welcome.
And with that, we wrap up the podcast. I really hope you found the information and the interview engaging and helpful. And for those primary care providers out there listening, I hope you'll think about CRPS when you're treating your patients with chronic pain. If you'd all be willing to take the survey that is linked in the description, I would really appreciate the feedback. Thank you so much for your time.